Well, it's about that time, so I'm going to formally welcome everyone to our Health Talks again. I'm Dr. Leslie Manson. I'm a clinical associate professor here in the Doctor Behavioral Health program at the College of Health Solutions. I'd like to thank you all for taking the time to join our Health Talks webinar, brought to you by the College of Health Solutions here at Arizona State University. The College of Health Solutions addresses the challenges facing people and communities to stay healthy, improve their health, and manage chronic disease. These talks are one way that we serve the community with timely and relevant educational content, that also provides continuing education for all of you at no additional cost. And please know from some housekeeping items, especially for that, is that these are being recorded. And all of these health talks are posted on our website at asuhealthtalks.com. And after each of our panelists present, we're going to moderate a question and answer session. You'll be using the Q&A features found down below. You should see a little box next to the chat that says Q&A, and use that to click on there and add any questions into the chat box at any time. At the end of all of our presentations today, then we'll moderate that discussion. Finally, at the end of all of this today at 1 o'clock, you'll receive a brief survey asking for your input about today's webinar. If you're requesting continuing education credits, that must be completed. So you'll have to click the link, go on and fill out all of your information. If you did not apply for CEUs, we'd still love and appreciate your feedback about our series. So the topic for today is using telehealth for better health outcomes. So I want to go ahead and introduce our two speakers today, Dr. Sink and Dr. Mayer. So Dr. Sink is currently the Chief Medical Officer for Bayless Integrated Healthcare, where she's been instrumental in leading the organization's telemedicine practice. Dr. Sink went to medical school at University of Arizona, so a local, and she is board certified in internal medicine and lifestyle medicine. Her career has also introduced teaching medical students and owning a medical home primary care practice as well. She's been the recipient of numerous teaching and top doctor awards in the community and is focused on delivering high value patient-centered care. So thank you, Dr. Sink, for being here today. Next, we also have Dr. Mayer. Dr. Mayer is a professional and a professor of practice at Arizona State University's College of Health Solutions here with us and teaches courses in healthcare delivery and palliative care. Prior to joining ASU, Dr. Mayer worked for 18 years at Hospice of the Valley as a senior vice president of clinical operations, developing relationships with numerous healthcare systems, businesses, and community organizations. He was a palliative medicine doc at Mayo Clinic for over 9 years and practiced general surgery in Phoenix as well. Dr. Mayer received his undergraduate degree from Arizona State University and went to medical school at Tulane University in New Orleans. We're very fortunate to have both of these professionals here to speak about their healthcare careers, their leadership, and we thank them very much. So I want to go ahead and get started and thank Dr. Sink to go ahead and begin with their slides.
All right, let's see. All right, is my slide showing correctly?
Not yet. We need a share screen.
It should be shared. Uh-oh, it's doing it again, isn't it? It is not sharing again, is it?
Nope, we've got it.
Nope.
You are
perfect. Okay, got it.
Great.
All right. It just popped up. I'm sharing screen. Well, great. Well, thank you. I'm very excited to be here to talk about this. I have to say, when I took my job at Bayless was an integrated program doing telemedicine already, and this was before the pandemic. I wasn't really aware of it, so I did a little bit of research on it. And the one thing that was really fun to see was that Arizona was actually involved very early. NASA came to Arizona in the 70s and was working on some telemedicine programs. And what we find going through is that for 60 years we've been doing telemedicine, but it really didn't stick. And now the world has changed and it has stuck. Whoops, let me go back. So first I looked like, is this something that we can do? Obviously, yes, we've been doing this for a very long time. Should we be doing this? Well, the science was really settled a long time ago that telemedicine can be very helpful and is either non-inferior or superior in outcomes and patient satisfaction on all kinds of things. So when I'm looking at the job at Bayless, diabetes, cardiovascular disease, chronic conditions, behavioral health, and addiction is what we do. And so this was something that was going to be very, very helpful. The little slide with all the green dots is just showing there's meta-analysis after meta-analysis showing that this is good care and people like it. But then kind of embarrassing thing is it's not inferior to what? And unfortunately, if we look at how we're doing on a lot of chronic diseases in our country, despite all our efforts and all the money we spend, we're not doing great. And our Healthy People 2020 and Healthy People 2030, unfortunately, don't set a bar of where we would like them to be. So it's not inferior, but that we still have a lot of room for improvement in what we do for our care for our patients. Do patients want telehealth? Absolutely. And going back for 60 years, all the patients have really liked it. And this is a really important fact for equity for our patient population, is to do an in-person visit is really a 2-hour investment of our patients' time. They drive, they park, they check in, they wait, we check their weight, they wait some more. We give them 5 minutes to talk to us. We talk to them for 10 minutes and then they leave. So you're talking about a 2-hour investment. If I'm an hourly employee, that's 5% of my family's income on this one visit. So you can imagine if my medical problems are not in control as a patient, I am not going to be able to come back and address them again. And what we found with our virtual care is the patient's in their life, and that might be at home, it might be at work. They can take a 10 or 20-minute phone call and they can get back to their life. And if things are not in control, they're open to coming back next week and talking to us some more because it's not such an impact on their day. Bayless, when I joined in January 2020, the blue bars, or you can see that's about the proportion of in-person appointments that we were doing for our therapy, our psychiatry, our primary care, and our care management. I joined in 2020. I was trained in virtual, and I did actually one virtual visit with a patient. And then March came, and everything changed. And so by April 1st, we had completely flipped, and the green is the volume of telemedicine visits that we were doing. Therapy was almost all telemedicine. Psychiatry would have a few medication-assisted treatment plans and people on long-acting psych injectables that needed for stability to come into the clinic. Primary care, we were really focusing on just the pediatric patients that were infants that needed their well visits, their vaccines, and important things like that. And then a few pre-op things for people with cancers that were going to go ahead and have surgery despite the pandemic. And our care management, our wellness training, our EAP was all virtual at that point. And if you look at our total volume, on the left is at the beginning of the pandemic, and that little gold line is what percentage of telemedicine visits we were doing. And you can see we had just an abrupt increase to almost all of our visits being virtual. And we actually, despite the pandemic, doubled our volume of patients we saw. The dark blue is our behavioral health visits, the middle one is the psych, and the green is our primary care. But everybody basically doubled in volume, and the patients loved it. So our patient satisfaction went up dramatically from before the pandemic to the after the pandemic. And these were pretty much the same population of people. Oops, sorry, I flipped ahead. These were the same population of people, but they liked it better. And you can see we had only 3% of the people that rated their care that they got from us 1 to 3 stars. And this is something that when we look at those people that their diabetes is not in control, their behavioral health problems are not in control, a big part of what's going on is that we need to get hold of them and have this ongoing relationship with them. And if our care is easy and it's convenient and they can get access to it, then they're going to show up and we can take care of them. And I think I missed a slide here. Let me skip back and look. Maybe not. I did, I lost a slide somewhere. The slide I lost was a quadruple aim. And when we talk about like what needs to change or what do we need to focus on, I think of things in terms of that. So first of all, the patient experience is fabulous, but the challenges in patient's experience fall into a few different areas. One is on the underserved people, they may be less likely to have digital access. And so we've actually allowed them to come into our clinics and use our internet and our location to have outgoing privacy. It's much better than you can imagine someone who is trying to do therapy within hearing of all of their household members because they have a small place, or people what we've had have been out in the parking lot in summer in Arizona trying to get some privacy inside their car. So we've opened up that patients can come in and use one of our exam rooms for their therapy, even though their provider is not actually there. The other area that's still a challenge is some language issues. You lose all the body language, and then sometimes having the translator is a little more difficult with virtual. From a quality point of view, I don't have information I can show, but we sit with our all of our insurance plans once a month, every month, and we look at our quality numbers. And what we found is exactly what we thought we would find, that this care is non-inferior to superior to when we were all in person, face to face. The cost, there's some important cost differences. One of the really key things is the overhead of just running a practice. So while we doubled in size and we hired providers like crazy, we did not have to purchase any brick and mortar buildings. And because we could find one building that used to support 2 people can now support 10 people. And we also found our staffing ratios had changed. And so whereas we had one-to-one staffing with the medical assistant walking people up and down the hallway, we are now able to get by with more like 3 providers to 1 medical assistant in a lot of cases. So just from an overhead standpoint and being able to have the resources to provide care, that gives us more opportunity to spend in places that are more interesting to the patients. One big challenge was the provider experience. So when you have providers, whether that is a nurse, a medical assistant, or one of the practitioners, we go into this job because we like to be around people and talk to people. And when we suddenly put them at home, sitting in front of a computer screen, feeling like a treadmill, there was burnout and there was isolation. And so that's really a challenge. And so the deliberate team building is important with doing all the virtual care. So we've now gone to a mix where we are 80% of our primary care people are virtual, and 1 day a week, they generally come into clinic, so they have a 20% in-person time. But we've also gone to a situation which I will refer to as Monday Club, where we have on Monday, our primary care can come into one of the facilities. They all sit in an exam room and do virtual care, so they're all actually still doing virtual. But you can come out to the hallway, you can talk to people, you can have lunch with people, you can have a meeting. And just that socialization actually we found to be tremendously missed when we were doing the virtual care. And integration, we are an integrated facility. And one thing that virtual care allows is instead of having this really disjointed and difficult and drive somewhere and go somewhere and do somewhere different, we can have warm handoffs virtually. So if my patient is experiencing economic instability that's interfering with their ability to buy medications, I can connect them right off with a care manager. And it doesn't have to be one who's just geographically near me. It can be whoever is available to help the patient at that moment. And likewise for therapy and psychiatry, we've lost the geographic limitation of, well, this person's available, but they're all the way across town. So it has allowed us to make our patients more supported with a whole person care wrapping around them and helping them to feel better. And I think that's why their satisfaction is higher. And I want to close with a quote from Donald Berwick, who one of his quotes was, "The office visit as a face-to-face is a dinosaur." And I completely agree with that. The product that we choose to make at Bayless is not our visits, it's healing relationships. And these can be done in different ways. And so telemedicine has been a fabulous improvement. It was just waiting for the sociocultural change that forced it to happen. But now the genie is out of the bottle. The care is good, the care is effective, the patients absolutely love it. And I think with making this easy for the patients, we will be able to, in the long term, prove that it's quality and it's better care for them. And so 80% of those visits in person weren't wanted by the patients, and the providers did not actually believe in them. And so now we've got a system that we can all support and believe in, and I'm just delighted with telemedicine.
Thank you, Dr. Sink. As a reminder for folks to put questions into the Q&A box at the bottom of your screen. And I'd like to welcome now Dr. Meyer, if you'd like to go ahead and pull your slides up.
Can you all see them?
Perfect.
Yep.
Great. Well, Dr. Sink, that was wonderful information. What a wonderful healthcare system. Thank you for sharing that. I'm going to spend a bit of time talking about Project Echo, kind of a overhead look of Project Echo. And I've included there the mission of Project Echo. And it's to democratize knowledge and amplify capacity to deliver best care practice to underserved populations around the world. It's important to know that all programs provide CME, CEU based on the members of the hub team and are free to the participants. A few objectives, just talk about the background, discuss a pretty straightforward telementoring model, which you're all familiar, many of you are familiar with. Discuss the framework of a standard echo session, give some information about some of the current and future ASU programs, and then a quick snapshot of the palliative care echo program that I've been a part of since August of 2020. Here's our founder, Project Echo, sitting straight up, looking sharp, Dr. Sanjeev Arora, and he's at the University of New Mexico in Albuquerque. And he developed the first program in 2003. And the program was designed to improve access for minorities and other underserved populations to best practice care for hepatitis C infection. Up until then, several things had been happening. Patients from rural areas had to wait sometimes up to 6 months to be seen in Albuquerque because that's the only place they could go. And they had, many of them had to travel 200, 300 miles to Albuquerque to the clinic. And that wasn't just a one visit. They would have to go back and forth during their treatment or workup and treatment. And that was due to a lack of training. Very few, if any, primary care clinicians offered treatment for hepatitis C infection at that time. And not a single patient in the correctional system of New Mexico had received treatment for hepatitis C infection. So started the program, developed these centers of excellence throughout the New Mexico and the rural areas, and quickly results started to show. Within 9 months of the start of Project Echo, patients had shorter wait times for appointments, and Dr. Aurora's clinic was able to treat more patients because the workup and treatment had already been started. Patients didn't have to start from scratch when they first went to New Mexico. So a lot of it was done, and many of them never needed to go to University of New Mexico. The information below is important, an article that talks about his experience with the 2003 start. It's a very straightforward model. There's core elements to Echo technology, most of the time Zoom, but it doesn't have to be totally by a Zoom. It's a combination of sharing best practices. Very important element is case-based learning. We almost always have a case to discuss, and important monitoring of the outcomes for each of the programs at the participant level. So you have a hub team of experts, depending on whether it's palliative care. Dr. Manson is involved with behavioral health. So you have a hub team. I think we have 5 members on our hub team. And that hub team puts together the information and projects it out to the audience, participants, and depending on the subject of the program, your audience will vary. And then in turn, the knowledge that is passed to the participant level then goes on to benefit whether it's patients, students, justice system, whatever, depending on, again, what is the program designed for and who's on the expert hub team. Anatomy of a typical echo session, they're usually an hour, but they can be an hour and a half. There's an introduction and then a combination of usually a didactic presentation and a case. And prior to the session, you obtain a case from the community, which is the most helpful to help them with something they're involved with. And during that time, again, case presentation, Q&A, discuss treatment, come up with recommendations, care recommendations, depending on a program. There's a summary, a survey, and then we provide the feedback to the case presenter and importantly, log participant information into the iEcho database. From little old Albuquerque, New Mexico, this is kind of where it is now. It's all around the world. Arizona State is the hub and a replicating center. I have colleagues in UK, Australia, New Zealand that are running echo programs. So it's growing dramatically. This is a list of not all, but some of the ECHO programs at ASU. Liver disease was the first one, collaboration with Mayo Clinic, Department of Hepatology, medication-assisted treatment, behavioral health, again with Dr. Manson's wonderful ECHO program. The VA, palliative care, nursing home was a one-year federally funded ECHO program where groups of about 30 nursing homes, we helped them over a period of 1 year in 90-minute sessions to deal with COVID. And that was during the times when it was starting and a lot of things were happening. So we kept them up to date. We educated. Some of the material we had prepared ahead of time had to be changed because of things that were happening so fast. And then human trafficking. Coming soon to an ECHO theater near you could be the substance use disorder for women. In March of 22, mood or medications for opioid use disorder, targeting judges dealing with those type of crimes and issues, substance abuse disorder, harm reduction, and a neonatal abstinence program. Community partners, familiar partners, is probably not all of the list, but some of the people we've worked with in the community. And some of the funding partners for our program. There's Hospice of the Valley and some family foundation, not sure about what that is, but and we've added two recent grants, large grants were just awarded by Access. So things are growing. These are some of the internal partners at ASU. Palliative Care 2020, every other Tuesday from noon to 1. Funding sources, as mentioned, and supported by ASU. This is the team, Adrian Matapetti, the head, Dr. Allison Esri, myself, physicians, social workers, a wonderful nurse from Honor Health Palliative Care, and a brilliant PharmD from One Point Patient Care. And of course, Mel helps us with all the administrative stuff. This is some of the curriculum we've had since we started, wide ranging. I was worried initially we might have to repeat, but we keep coming up with topics: palliative sedation, pediatric perinatal palliative care, etc. So we've been able to have great speakers and great topics. Just some ending information. Total of 32 sessions through 2022 January. Unique attendees, learning hours, and CME distributed. And here's the breakdown of our audience. Again, healthcare providers, physicians, NPs, PAs, nursing, etc. Behavioral health specialists are involved in other. We have a fair number of other leadership, hospice palliative care management levels, practice managers, educators, and academics. So a wide range. And so you tailor your level of complexity and presentation to your audience, obviously. And here's one slide that kind of gives a summary of some of the data we've accumulated since we started. Again, a high 4.88 satisfaction, increased confidence in the ability of our participants in those listed areas. And important point is that we've increased the number of palliative care providers that are treated by our ECHO participants. So, and last but not least, this proud father says, thank you for listening.
Thank you, Dr. Meyer, and what a beautiful picture that was. It's always wonderful to see something personal. So I want to go ahead and, as that reminder, go ahead and push the QA button at the bottom of your screen and consider asking some questions about Project ECHO or how you might begin to actually implement an ECHO of your own. I have a few questions already established, so I'm going to go ahead and start to moderate those questions now for everybody. Okay. So first we have from Matt Donovan, we have a question. So Dr. Sink, what, if any, limitations are there for people who choose telehealth that may need otherwise traditional in-person services? So that's the first part of this.
Okay, so the way we have our setup is that we try to have at each of our clinics one provider in person every day, and the other providers associated with that clinic are doing virtual. So if we have a situation where a patient just needs a simple in-clinic service like a urinalysis or an immunization, they're actually able to be booked at any clinic that is close to them. So whereas I may be in North Phoenix, I may have a patient in the East Valley and she can drop into our Dobson to have her blood drawn or get a vaccine. And then if people need something that is actual an exam, for instance, I had a patient that had some leg pain and I wasn't sure, is this peripheral artery disease or sciatica? And they're wanting injections from a pain medicine, but I wasn't sure that was right. I'm able to set them up with a colleague close to them to do that physical exam to evaluate what needs to be done. So we work as a team, and it doesn't have to be team to space at our site. It can be whatever is best for the patient.
I love that discussion of how you are operationalizing as a team with everybody doing that. So that's great. Another part of this question is, are there complementary approaches to other kinds of historically in-person services also transitioning to support more telecare-based models? So other complementary approaches to other kinds of in-person that you're offering there?
I'm not sure what the question is asking.
My understanding, and Matt, you can always post another question here, is are there any other approaches that you might be doing outside of telemedicine for historically in-person services? So if you're doing, are you transitioning, we heard behavioral health to also telemedicine, we heard physical health, any other type of specialty or other types of?
Pretty much everything we have transitioned to virtual care, including medication-assisted therapy as allowed by regulation. So about the only things that we are not are the very infant checks, because the small under 1 year old coming in for a well child check is very difficult to do virtually. But pretty much everything else, including therapy, we are doing all virtually.
Wonderful, thank you. And do you have care management online as well?
We do. We have care managers, and we have people who are typical traditional case managers. We also have care managers for chronic disease, which includes nursing and education. And we also have an employee assistance program for some high-risk employers that offer therapy online and other types of health coaching online to help avoid burnout and stress from certain employment situations.
Wonderful, thank you. I'm going to go ahead and give a question next to Dr. Meyer. Dr. Meyer, related to Project Echo. Project Echo, they say this is very interesting model. Do we have data on how patients have directly been impacted with the model? Patient health outcomes in specific, healthcare access, and so on. Congratulations on your daughter's wedding.
Thank you. I've got one more next year. So yes, we do. In fact, we're in the process of collecting it for all of the programs, not just palliative care, and putting together a report. In our program, it's a little difficult to get that outcome component because it's an educational component, and but one of the pieces of data that you saw was that more people are providing, more participants in our audience are providing palliative care consults. Behavioral health, I'm not familiar with what you're tracking there, but again, that's opioid use disorder. Yes, getting some outcomes from the care centers where patients are being treated, and et cetera. But yes, there's data being collected, and I think we're starting to go deeper in some of that data.
And just to add to that, Dr. Meyer, is if you go to New Mexico's, the main Project Echo website, you'll actually find a little bit about the research and the data from all the Project Echoes that are worldwide. And in addition, the federal government actually passed legislation specifically to support Project Echo called Project Echo legislation. And that actually has a lot of the health equity and outcomes data that provided that support within that. So there's some information from that legislative act as well.
Yeah, that's a great point, because there is a phenomenal amount of data on that website, and some of the other programs that are out there, actual sessions of programs, et cetera. So great point.
So next, I'm going to go to Dr. Sink again. This is from Michelle. She asks 3 questions. I'll start with the first one. What are the scenarios that a telemed might lead to a request by a provider for the patient to be seen in person? So scenarios that a telemedicine person would say.
Okay, we thought that was going to happen a lot when we first went into this, but it turns out there's not that much. So the situation I just brought up of a patient where leg pain, and do we think this is peripheral artery disease or sciatica? That was one of the rare situations that has happened. A lot of the things that people would come in, say, wanting antibiotics for are things that maybe antibiotic is not the right treatment anyway. So the relationship and the discussion about why all sinus problems don't need a Z-Pak can actually be handled virtually. So it turned out there are not actually a lot of situations to do that. And people have a tremendous amount of ability at home to do their blood pressure, check their weights, check their pulse ox. Everybody has a pulse ox at home now. So if you have somebody who's borderline with COVID, they can actually check their pulse ox and tell you what it is. We thought we were going to have to get the equipment like for otoscopes for people to put in at home because that's an available thing, but we actually have not needed to do that. So we haven't invested in that system.
Next question. If there are research teams working with long haul COVID, is your clinic interested in collaborating for those who don't have access to a local long COVID clinic?
Obviously, long haul COVID is a very interesting question that's going to be developed. And we were approached by somebody, but I think at this point, we're kind of standing back because this is a big question for a consistent question and evaluation that probably is going to be a federal or a large university doing it. So we're not going to jump in, but we would be happy to be a piece of it if somebody has a really good research question and design and support system to try out.
I almost want to put a nod to Dr. Meyer there in his talk about Project Echo. Perhaps some groups might want to get together and design in Project Echo just for that. There might already be one if you search the Echo websites right now.
Yes, there are a lot of programs out there around the world, as I showed on that one slide. So yes.
Next for Dr. Sink, some telemed becomes limited due to state guidelines that the provider must be in the same state as the patient. Does Bayless see people from across the United States or are there limitations there?
We right now, our main primary care sees people that are only within the state of Arizona. We do have some EAP programs where we see people in other states that we do, and it's under discussion, and it's very dependent on the state, and some of it you have to be present, and some of it can be somewhere else. So right now we've decided to restrict it to just Arizona because we've actually can barely control our volume here as it is.
Thank you, Dr. Sink. I'm going back to the questions again. We have another question from Mario. He has a question/statement as well. Curious if there's been any change noticed in which type of visit that patients prefer or request. Are you noticing more people preferring in-person versus telemedicine from earlier in the pandemic to now?
So early in the pandemic, a lot of our elderly patients and our immune-compromised patients were obviously scared to pieces and wanted to stay out of the clinic. So they were delighted to not come in. And some of our patients were reluctant about the technology. Now, one thing that was funny is that went on long enough that people who have medical problems and needed refills and needed shock actually got a chance to try it out. And a very large number of people that I would not have otherwise thought would be great with this can manage it. So I've got an 80-year-old woman who lives in assisted living who messages me through the portal all of her little information before her visit. We're able to loop in her son to the visit from somewhere else, and he can sit in and have the visit with her. And she really likes it. And so some people do want to come in. Part of the socialization used to be the waiting room, honestly. And we don't allow that anymore. So people come into the waiting room, they get their temp, they get their screen, and they get put back in the room. So the visits are not as chatty as they used to be. So yes, some people want to come in, but I think a surprising number of people find out that it's a pretty nice way to have a visit, and they feel heard and spoken to better, maybe than with all the walking and rushing and the waste of time listening to a heart that wasn't really relevant to that person's complaint anyway.
Thank you. Dr. Meyer?
Yeah, just a comment about reaching out to other states. One of our participants, or a couple of our participants are involved in multi-state palliative care programs. And the physicians and the caregivers need to be licensed in all of those states. But, that's an example of where we can go in certain ways with certain organizations to other states and deliver palliative care and be involved with some of those complicated cases that are out there that we present and help manage.
Thank you, Dr. Meyer. And just a secondary note on that, I know that there's actually a few large-scale ACOs locally here that have offices throughout the United States, and they'll often have their providers be dually licensed in other states so they can provide care across those state lines. So that does happen a lot. So we did have another comment from Mario saying, yes, now we have actually more options for patients to see people, and that's great. So that's that comment of, wow, interesting how people have this and how they're utilizing these new technology pieces. We have another comment and question related from Agatha. She notes we were doing well with telemedicine at the height of COVID-19. Then we started to notice patients wanted to come in for that socialization that you already noted, Dr. Sink, and or to try to show something to the physician. So those other types of specific appointments. And so they're noticing that too. So just the comment. And then the other question part of this is they would like to know if you've noticed or know of any type of concerns or questions or comparisons in your billing and reimbursement coverage from insurance. So looking at in-person visits to the telemedicine visits. Any comments about that?
Well, a lot of parity with the visits, so it's really not an issue at all right now. Now, things may change going forward, but I think people are so happy with the telemedicine opportunity that they don't want that to be taken away because the insurance downgrades the price of the visit. The other big change we've noticed is actually completely separate, which is the CPT changes for 2021 allow a time-based billing, which is actually much more useful. So a lot of our visits are actually time-based, and what the patients find is instead of getting the 11 minutes, they're getting 26 minutes of FaceTime. And so that makes it actually a much better experience for them.
Thank you. This question is to both of you. Just Jimmy noted, just considering and tackling the industry gap related to telehealth appointments to non-English speakers. So if you could comment on interpretation services that are currently perhaps actually often difficult to integrate into EHR systems, and any recommendations or thoughts about that?
Do you want to go first?
Oh, keep going.
Okay. Well, one thing we found is sometimes the integration is actually, the translation services are actually easier. So we actually have an app and you can tie them in and you can pull them into their phone call, just like adding somebody to a Zoom call. And frequently we would have people, for instance, American Sign Language interpreters that would have to physically come and be at the clinic and match the time to when the patient was there, but also when the provider got to that point in their schedule. And we would have a lot of trouble with the interpreters like, I've got to leave and you're running 30 minutes behind and we missed the visit. So in some ways, the body language and sometimes the subtle things of communication are more difficult via the internet, but I think sometimes just getting an actual translator who's a real medical translator becomes less of an effort, and that's probably better for care.
Yeah, I'm aware of several programs across the country, especially Southwest and West, where the programs are in Spanish. And, you know, it's technology, at least in my experience with Echo, is not there where you can translate an English presentation into Spanish at the same time, you know, with captions or something. I may be wrong, and Dr. Manson may know about that, but that would be something that would be ideal, to have that translator at the same time for someone who could, the programs in English, but they're able to get the content in Spanish or whatever language. So.
Oh, you're right, Dr. Mayer. I don't know. I've never used any type of translator piece of that. I do know that some of the echoes that are international have translators, just like Dr. Sink was noting, live on there, and then they will distribute the information in that way, just like utilizing a established certified telemedicine translator. So I want to go ahead and go to kind of a workforce and workflow question to Dr. Sink is Bayless utilizing video for televisits or simply telephone visits? And when medical assistants are working with a virtual provider, do they go to clinic or is it remote?
Okay, so we try to do almost all real-time audiovisual visits. I find it much better to be able to look at the patient and look at the kind of frown on their face if you ask them something. I find that's a very important piece of the communication. And what we have found is with a couple, we have multiple aspects of ways we can get to the technology. So almost all of the patients are able to get it. If we really need a video visit and we're not able to get the person on anything besides the telephone, again, we can invite them into our clinic to use our equipment to do that. So the telephone visits are a minority, and we really push to get the real video. And I'm sorry, I forgot what the second question was.
For the MAs, are they actually present in the clinic or next to the physician, or are they remote?
Yes. So right now, the way we have it is initially the MAs were all set in the clinic and they were actually distributed out to the exam rooms. And so they were very lonely in a little closet by themselves all day, basically in an exam room. Now that we're able to get a little more contact, they are actually in clinic and sitting in nursing stations again. They have a hybrid plan, so they can be in person and then some days work from home. So it's a combination thing, which is very helpful. It's a little hard with work from home and patient privacy because we have to make sure that they do have a room with a door that closes and privacy that household members would not be able to come in and see it. And so they would only be able to go home and work from home if they can establish that they have a private place to do the job.
I love how you work those little gems in. So that's important. And again, to really see the quad aim in practice. So that's great. Next question is for Dr. Meyer. So Dr. Meyer, for folks who haven't heard of an echo session really, or haven't seen it in practice, could you explain a little bit about how it works? Is the presentation like this, where then there's questions at the end, or what have you seen the most common?
Yeah, and I described two different. The normal session is an hour, and the content and the topic either comes from the participants. They want to hear a presentation about something, pain management, whatever it is, pediatric palliative care. And so a presentation is put together, and the time format is about 45 minutes for that part. And you always base it on a case. Hopefully the case will come from the audience, the participants, because then you help them with a difficult situation. But if not, some of the members of the team can come up with cases because we're all practicing. And then during that, you have not just usually one case. We tend to have multiple ones depending on the topic that flow through the presentation, the didactic or learning part of the it's kind of combined, and taking questions during and at the end, and then coming up, if it's a situation that involves some kind of program or treatment plan during that conversation, we kind of wrap up what's come up in the conversation. Many times good comments and information comes from the audience, and then we kind of summarize it. And the one program I mentioned, which was the nursing home, that was an hour and a half, and that was over a year, federally funded. And that had a combination of things because things were changing so much in nursing home. The content that was created before we started somewhat got out of date, and things that were thought to be effective weren't. And so that was a program that over 90 minutes that we just had a combination of cases, problems from the audience at what was going on in their nursing home, CDC recommendations. And so that's just a longer version, but they're a combination, again, of a case, information, questions, and summarizing the program.
That's a great example, Dr. Meyer. Any other questions related to that piece for Project Echo, just to make sure that we've answered those for folks? And then just as a reminder, all Project Echoes are free and they provide free education in CE. So anyone who joins is able to do that. Just like at the end of this promotion today, you'll see a little note that pops up in the chat box. You click on that and you complete your CE, and they are across the world.
Mm-hmm.
So we have about 10 more minutes for question and answers. So please go ahead and submit any questions into the chat box. And just for folks to know is there's so many different topics for Project Echoes, everything from general surgery to specific areas of learning about medical conditions, then to obviously very different perspectives as far as specialty medicine and care as well. So many different areas.
Yeah, and that one that's coming up that I mentioned with the judiciary, I have that daughter in the photograph is a federal public defender and deals with, opioid crimes and things like that. So that's going to target judges that are involved with those type of cases. And so you have, again, judiciary, public justice. It's a wide range. And on that ECHO site, the main site, you can see the different programs that are out there.
And they also provide, some of them do provide live care scenarios with patients. So just depending on where they are in the world. So I do want to say one of the last questions that we have posted right now, and I know there's might be some folks typing in as well, is this is a question for both of you to just note anything that you might have seen being utilized or be utilizing at your programs related to remote patient monitoring or RPMs. So both these programs use telehealth type of technology, but RPMs are very specific, right? And Dr. Sink, you noted a couple of RPMs in some of the discussions, noting like some of the things that you were encouraging people to look at and use. So what types of aspects have you all heard about or seen most commonly utilized for RPMs?
So RPM can be very effective, and there's a lot of studies for things like congestive heart failure with people monitoring with that. We have not actually set it up at all. There are a lot of companies that will provide it as a service and provide the equipment. There's a big logistic effort that goes into that. And so we've actually just have not gotten to the point of doing that yet. And we may at some point, but as of now, we have not dived into that.
Yes, I'm very familiar with Hospice of the Valley and Arizona Supportive Care. In fact, I remember 10, 15 years ago, I brought some clunky scale and blood pressure cuff that we were going to start to use in the field. And that's come a long way. And they do virtual visits for the palliative care patients. They have scales for congestive heart failure patients, so they're checking their weights. Lots of different apps out there, as you now know. I was at a trade show in Austin over the weekend, and a colleague of mine has developed one of those smart rings. But oh my gosh, what that thing can monitor and then send to a physician is more than the watch. And so, yeah, I think that we just scratched the surface on some of those remote patient monitoring, whether it's for palliative care, acute care medicine, internal behavioral health, whatever, so many things.
There's lots of technology, apps, et cetera, whether it be driven by the patient who wants remote patient monitoring related, and also obviously driven by tech companies and the EHR systems that link up together to be able to offer those services. But also there's a lot of ethical pieces there that people are still working out as physicians, as clinicians, and within their own healthcare practices. What is this going to look like, and how should we utilize this, and how can we communicate this to the patient? So great questions. And we'd love to hear from anybody else if you have further questions, whether it be on this topic or any other topics for Dr. Meyer and Dr. Sink. And while we're waiting on a couple extra questions to see if there's anything else, it looks like we've got some comments already popping up. So some folks have been saying, yes, RPMs can be very useful, especially with specific types of chronic diseases like diabetes. And then we have another question of, do you think insurances will stop paying for telephonic only visits? So that's the first part of the question for both of you.
I think they're trying to encourage the real-time audio visual. And so I could see a day definitely where the telephone visit would be downgraded financially enough that it really pushes the providers to do something else. So I expect that to happen. I think it's going to be, the standard is going to be real-time audio video. And then it'll be a matter of how do we get that to the people that don't have the access to the technology.
Yeah, I would agree. It's the visual of something hanging on the cliff, and it's about ready to maybe fall off, but hopefully not fall off all the way. Because again, look at the data that was presented earlier about the acceptance and the appreciation of that component. And so to me, it would be foolish to totally get rid of that reimbursement.
Secondary part of the question is, how do you handle the patients who refuse video calls? So Dr. Sink, any hints from your organization or from you?
Well, we have tech people that try and coach people through it. So if the problem is refusing based on I can't, or I don't know how, or I'm afraid, we try really hard to find a way around that. There are some people that we leave it in the provider's decision, who knows the patient. If they feel that a telephone only visit is better than no visit and they're able to be safe with that visit, then they can go ahead and do it. However, the provider also has the option of saying a telephone visit is just not adequate for that problem. And if you need to come in, you can come into the clinic close to you and see a different provider, but we need to lay eyes on you.
I have some personal experience. My wife, she said she used to practice in little old ladies at Mayo Clinic. She had patients for 35 years, and most of them were elderly. And she would be trying to start a video visit and, trying to coach the patient through. And then many times at the end, well, it turned into a phone call, which is not as valuable. So again, yeah, it is a problem, and I think it depends on the internet access, the age of the patient, how tech savvy, and sometimes it ends up just with a phone call or now in person.
Thank you both. One more question here thus far. What does the programs look like, for instance, offering medicine post, and I believe what they're referring to is the public health emergency, PHE. So post PHE, post public health emergency, what impacts are you foreseeing is going to now be changed? What insights do you think might be coming up with legislation? Any thoughts?
I think that the American public has experienced telemedicine and loves it. And I think the providers have been forced into something that they were not willing to change, but now that they've done it, they pretty much like it as well. And I think it's going to stay around. And I don't see a lot of strict legislation coming into as far as you can only do it in this narrow circumstance, because I think the experience is broad enough now, and based on the research going back 20 years, that this is good. I think it's going to stay, and it's going to be an option. And there may be people who prefer to come in and have most of their care in person, but I think it's going to stay, and it's going to be a large part. And I think Donald Berwick was right that about 80% of the face-to-face visits were not really necessary or desired, and we're going to do them a different way.
Yeah, another choice for patients, and which is always important.
And we need to be looking at that access piece. So I agree with both of you on this. It's another way to be able to really help provide, hopefully in some ways, more equitable services. But at the same time, we need to really look at how we're defining equity as well related to this. Some folks had commented as well. Agatha noted she agreed with these pieces. And then looking at the patient demographics, seeing that they also have experienced patients who don't want to be on camera, who have difficulties or have connection to internet difficulties as well. So really how to develop programs to really support all patients and their services. Agatha also notes that they also experimenting and trialing out hybrid, and a couple of hybrids, one in person and then check vitals, et cetera, and then doing more of a telemedicine visit as well. So it looks like folks are really coming up with different ways to offer services to patients. Wonderful to see all the chat. We only have a couple more minutes left. So for those of you who are joining us on right now, feel free to type your questions in the Q&A box. Soon, we're going to put a link in the chat box for the continuing education and the feedback. And we'd love for you to go ahead and click on that and do that at the end of our session today. So just a reminder, that will be popping up soon for our folks. Okay, so it looks like we don't have any other questions, at least popping up right now. If they do, I'll go ahead and announcement. But I will want to say thank you everyone for joining today, and a special thank you obviously to Dr. Sink and Dr. Meyer for taking the time to be here and to present, and obviously to share some wonderful insights for them personally and professionally. So thank you all for joining us. We encourage you to follow the College of Health Solutions on social media. Okay, we have multiple social media accounts on the screen. You can also learn about other opportunities like this one. And there's also a link to Project Echo in the chat box if you'd like to see and learn a little bit more about Arizona State University's Project Echoes. And our next Health Talks webinar will take place on Thursday, April 21st, also at noon. So Thursday, April 21st, noon, that's Arizona time. And we'll be addressing the topic of using big data to improve population health. So using big data to improve population health kind of works similar to some of these questions people have asked. So additional details will be announced, and registration will begin opening soon at asuhealthtalks.com. We do have another comment and question that came up. So if Dr. Sink and Dr. Meyer, if you have one moment to kind of hear one more question, it is, what do either of you most wish medical students knew about your work? I love that question. So what do either of you most wish medical students would know about your work?
Well,
Go
I'll
ahead.
start. You know, it's just how gratifying it is to be a part of a program and reach out to the community, work with a team of experts, use my past experience, not so much with surgery, but palliative care and hospice, It's a very easy format to use and to be involved with. And I think it's, I encourage some of the students I'm teaching now to attend this health talk and echoes. And it's just a wonderful model. Again, it's not quantum mechanics, but it works and it's rewarding and it builds another way to build a bridge to the community.
Dr. Singh?
So I would say from mine, the aspect that I would really want people to understand is that the way Bayless's integration works. We have so much time that the medical students are taught the person needs to do this and needs to do this and needs to do that. People can't do what you tell them to do. It's hard to make change. And I think the main thing is we might understand what we would recommend for them, but being able to understand where they are and what support they're going to need to make those healthy changes is how things really happen. And that's one of my things I really liked about my lifestyle medicine board certification is it's really helping people make the choices, not taking the pill that is going to make them well. But that is really a team sport. And it's not going to be them in their career telling somebody, hey, you shouldn't smoke. And the patient goes, oh, you're right, I shouldn't. And they quit. It's a team sport. And that's what the integration model I love about it.
Great. We'll have one more question, and that's probably going to be enough for today as far as our time. We have one coming in from CR Mackey. He asks, what are the key strategies and related telehealth skills that CHS, the College of Health Solution, could do to best train their students across our programs? Anything that comes up?
Be involved with it. Use it. Don't miss an opportunity to whether learn or connect virtually and just expand your own information and experience with telehealth. And a lot has happened since 2020, and it's been a wonderful transition and very valuable. So experience it.
Dr. Singh?
And I would say the lesson really is with telemedicine that this caring relationship is a conversation. And you don't have to be there and touch the person and feel their pulse to have that conversation. You need to listen to them, look at their face, understand where their questions are and what questions they don't want to ask, and really be involved in that conversation. Because that's how people develop the trust and the faith to take what you're doing and apply it to their life. And telemedicine allows us to do that beautifully.
Thank you both for those answering all of these questions. I do want to relate that many people also place a lot of just thank yous and generous, gracious comments in the chat box as well about both of you. So just extending that thank you to both of you and your time today. It is 12:59, so it is time to close. Thank you again for everyone joining us today and to our speakers. And we look forward to seeing folks at our future talks.
Wonderful, Dr. Manson. Thank you so much. And Dr. Singh. Great.
Yeah, thank you.